modifiable risk factor for uterine cancer. So the bulk of the malignancies I see. But we also see ovarian cancer, cervical cancer, vulvar vaginal cancer, gestational trophoblastic disease.
Dr. Brittany Davidson, welcome to eShadowing. How are you doing, my friend?
I'm doing well. How are you?
I am wonderful. I'm excited to chat with you and 175 of our friends. A fun specialty, gynecologic oncology.
Yeah.
What leads to someone wanting to be, as we were just talking about, in a specialty where no one is excited to come to you?
Me? No, it's not something that I ever imagined myself going into. I think most people, when they go into OBGYN, are pulled because of the baby delivering these happy, wonderful, joyous moments, that was me. I thought, gosh, that I want to deliver babies. I want to be part of that joy. And it was wonderful. I loved obstetrics. And then I rotated through oncology my second year of residency, and I simply fell in love with the patients. These women are incredible. They have such grace and are going through some of the most challenging times in their lives. And I feel like they teach me as much as I teach them. And I love operating. And so to me, it was getting to do the things I like to do with the people I like to do them with. And so it was a huge surprise, but I truly can't imagine doing anything else.
So as you were talking, I don't think I've ever thought about it in this way, but I'm going to ask you a question and you can tell me if it's potentially right or way off base.
Okay.
Normal medicine, right? A patient goes to see an OB because they're happy, right? They're having a baby or dealing with normal kind of women's health stuff, potentially. There, in our society, there's a lot of entitlement around being a patient and how, especially around the baby birthing world, how they want everything to be, and potentially rubs off on doctors the wrong way, potentially versus in your world, patients are coming to you almost as I have no other option but to see you. I need you. Help me. Do you think that, because I hear this a lot from oncologists, I'll just leave it at that, from oncologists, that they just love their job because of the patients. And I think there's a wall that comes down between the patients and doctors, that it's like, I'm here at your doorstep, help me. And not to say like, oh, I'm the doctor and I'm the only one that you can rely on, but the relationship just starts off on the right foot because there's a mutual respect there.
Yeah, it's really interesting. One of the first things I tell my new patients when they walk into the room, and I say, I can imagine it was really hard walking into the cancer center today, but you're in the right place. We're going to figure out a plan together and we'll keep moving forward. And I say that to every one of my new patients, because acknowledging this must be so scary. And I don't understand because I've never been in that position as a patient, and they truly are in the right place. We're going to figure this out together. And so I try to empower them from that point and say, I'm not sure what the future is going to look like, but you and I are stuck together, whether you like it or not, and we're going to move forward as a team. And so I try to empower them and sort of right off the bat, develop that relationship. And one of the important things to me that I always keep in mind, or at least I try to, is that yes, I might be the expert in GYN malignancies and sort of the medical ease of what's going on, but the patients that I'm seeing, and really any of us are seeing in medicine, are truly the experts of their experience, right? I don't know their life lived up until this point. I don't know their symptoms. I don't know their history and perspective that may drive them to have a particular set of views about doctors or views about medicine. And so I try to remind myself, this is a conversation between two experts.
Yeah. I wish all doctors had that thought process, because what you just described has a very simple definition, or simple word that defines it. It's called empathy, right? Yeah. Trying to understand who that person is in front of you. Wonderful. What is bread and butter gyn-onc?
Bread and butter gyn-onc, obviously, so GYN malignancies. Uterine cancer, by far the most common malignancy that I'm seeing. As the obesity epidemic persists and grows in this country, that's the number one modifiable risk factor for uterine cancer. So the bulk of the malignancies I see. But we also see ovarian cancer, cervical cancer, vulvar vaginal cancer, gestational trophoblastic disease. And then sometimes we just see really complicated patients with benign GYN issues that need surgery, and maybe their regular gynecologist doesn't feel comfortable for whatever reason. They're too sick. They need a special kind of surgery. They need to be at a tertiary care center. And so I do see a minority of patients without cancer. And so every day looks different, which I find enjoyable.
Yeah. I'm going to potentially push some buttons here, and I apologize in advance.
That's fine.
I'll ask it in a soft way, hopefully. The majority of students watching this right now are not going to go on and be gynoncs like you are. They're going to be family practice, internal medicine, primary care docs.
Mm-hmm.
How do you balance the kind of shift in our society of body positivity, knowing that obesity on the other side leads to more patients coming to see you?
You know, I struggle with that every day. And I was actually talking with some of my medical students in the operating room about this, because on the one hand, I want women to feel empowered. I want them to love their bodies. It's truly the only one they're going to get, right?
Yeah.
And I struggle with, yes, there's a range of sizes. Yes, you can be healthy and a size, whatever. But I know that peripheral estrogen that's being made by those adipose cells is putting you at risk. And I don't have the answer to that, but I struggle with that.
Yeah.
And so trying to figure out with women, like, what's the best version of themselves? How can we mitigate risk? How can I don't know. I wish I had the answer.
I think that what you just said, which I think I remember from medical school, but we don't hear very often, because all we talk about is being overweight is bad, go lose weight. And there's not a lot of potentially why behind it. And patients obviously are coming in already on the defensive, potentially. But what you just said of adipose cells, right? Fat cells release estrogen.
Yeah.
Right. And knowing that, it's like, okay, now I can put 2 and 2 together, knowing that excess estrogen is bad for my body. It's not just having excess fat cells, it's what they're doing to me.
Exactly. I'll have women who are in their 70s who come in and say, gosh, I've started having periods again. Isn't that funny? Not really funny.
No.
There's a reason. Let's talk about it.
Yeah.
And so some of my partners and I differ about what our role is in terms of helping women consider weight loss or weight stabilization or things like that. And so I usually start off the conversation, how do you feel about your weight? Some women really want to go down there and have that conversation, and others are not interested. And it's not my job to convince them one way or the other. It's to share what my experience has been. And if at any point they want to go down that road, I can figure out how I can help them.
Yeah. Awesome. So I would love, I know you have some slides to present. I would love to jump into some slides and we can continue to ask questions as we do that.
Sure. Let me see if I can make this screen share work. Let's see. Share window. Let's see what I got. All right. Let's see. It claims I'm sharing. I'm not sure that it's actually sharing though. Let's see.
I don't see anything right now.
I don't see anything either. Here we go. Let's try the Chrome tab window, Microsoft PowerPoint, and share.
Ta-da. No, I don't see anything.
No, I don't either. This is very frustrating.
I told you, they changed the whole interface.
Wants to share the contents of my screen, and I'm telling it to. I don't know. Well, maybe I can walk people.
Do you want to email it to me and maybe I can do it from my side?
Yeah. Gosh, technology.
Love
Blessing and a curse. It's a blessing and a curse. All right, let's see. I'm going to email right now. I'd be happy as I'm trying to figure out technology. If people have questions, I'm happy. Or I can just talk about why my job is wonderful.
So here's a great question from Megan, someone who understands potentially adipose cells. Do adipocytes of formerly obese women still produce excess estrogen? Because for all of you listening who don't know, once you get an adipose cell, they don't go away unless you physically remove them. That's
fair. Yeah, we think though, even though those cells are still persistent, they're actually doing less. Yeah. So there's less aromatase enzyme kind of functioning. And so we do think that, there, I just sent them, Ryan. The answer is yes. We do think with weight loss matters.
Yeah.
Absolutely.
Right. I would assume so.
Yeah. All right. So let's hope that works. One of my favorite things to talk about is gestational trophoblastic neoplasia. So I put some slides together about that because it's such a strange entity and it's very much the younger patient population I take care of. And no one thinks you can get cancer as a result of a pregnancy, which is mind-blowing to many people. So just thought, fun fact, not all patients with gynecologic malignancies are old. I have treated someone as young as 15. So yeah,
it's amazing. I know people, pregnancy, just how bad it is for the body potentially. I know people have had to have,
in a lot of ways.
Who have had to have heart transplants post-pregnancy, who have had to kidney transplants post-pregnancy, just the body just freaking out.
Yeah, it's not for the faint of heart, having gone through it a few times.
Ugh, all right. I still haven't gotten them. So
Oh no. And I see Allie, yes, adipose cells make estrogen in males too. So women make testosterone and men also make estrogen. Back.
they're not exclusive
They are
hormones.
not.
Let's keep chatting and I'll see if they come in. Whatever.
Maybe do I have capacity to actually share? Because when I try to share, it grays out again. So I don't know. Do you have to let me?
No.
No, I don't know.
No, you should have all of the privileges.
All the privileges. Well,
you have administrator access. I could revoke it, but that wouldn't be very
no,
fun.
that's probably not fun. What if I try to share my whole screen? Let's see what happens there.
Let's do that.
No,
just doesn't want to
a whole
play
lot
nicely.
of nothing.
All right.
No,
Wow. Are there any videos or anything in there?
Oh, well, it lets me share my.
Oh, hey, look at that.
Yeah, it lets me share that. That's not helpful. I'm going to stop sharing that.
Are there any videos or anything in there? Any animations that are important?
No, there aren't, but there's some path pictures and
so click on
stands.
Click on slides underneath the chat. Do you see slides?
Underneath the chat, yeah.
So click on slides and then click on add a new presentation. Let's try it that way.
Okay, let's see. I have to have the presentation name.
Just go, duh.
All right, let's see what we can do. Come on. All right, it says they're uploading and processing. May take 2 minutes.
All right, perfect.
We'll see.
So we talked about bread and butter stuff. Let's talk about the surgical side of it. The again, kind of stereotyping and playing into some potential touchy topics. There's a lot of pushback usually from others when a woman says they want to go into a surgical field and say, well, what about having a family? And what about this? What about that? How do you handle that realm of negativity around women in the operating room?
I think number one, if you love a field and you feel like it is your calling, then you should go for it. I met this resistance at every step when I thought I wanted to do OBGYN. So applying in medical school for residency. In residency, when I decided I wanted to do gynonc, I was told, oh, you're too nice. When are you going to have kids? Things like that. And I thought, I could do something different. I could do an outpatient, field. I could go into dermatology. Their hours are much better than mine. There's not a whole lot of dermatologic emergencies, but I'd be miserable because it's not what I enjoy doing and work would feel like a slog. And so number one, I think to me is go into the field that you like. It's not easy, right? It is not. But what I will say, there are more and more females in leadership in medicine and change is happening. Yeah. It's not always as fast as we want it to be, but it's happening. Whether it's maternity, parental leave policies, breastfeeding policies, family support, it's happening. It's just, it can be slow sometimes, which can be frustrating. But if it's truly what you love, then I would say go for it.
Go for it.
Awesome. All right. Let's see. Now it says preview. Yeah.
Preview and then start or.
Yeah. Let's see. Yeah. How does that work?
There we go.
Cool. All right. So the slide set was originally made for some fellows. And so I tried to know thy audience. And so we'll go through some of these things in a more broad swath. But GTN is gestational trophoblastic neoplasia. So these are malignancies that happen in women after pregnancy. And it can be something called a molar pregnancy, which is an abnormal pregnancy. There's not a viable fetus there. It could even be after a term vaginal delivery. I've had patients who've had a nice healthy baby and then 6 weeks later, boom, they have a cancer diagnosis and are on chemo. Oh, this is not updated slide set, but we'll go through it. So GTN was actually the first solid cancer that was ever cured with chemo back in the 1950s, which is really cool. So like I said before, these are young patients. So this patient, she is 20. She just had a pregnancy. It was a molar pregnancy. So one of those abnormal pregnancies. She had a DNC, which is basically getting the pregnancy evacuated from her uterus. And she comes to see me because her beta HCGs or her pregnancy level after her DNC started to go down, but then it started to creep up again. And so after molar pregnancy, we're following these blood tests on a weekly basis. There are certain criteria to meet diagnosis for GTN. after a molar pregnancy, about 20% of women can get cancer. And so it's something that we're looking for. There's lots of different ways to diagnose it, and the diagnosis is really key. The pathologists help us both by doing some stains on the slide, but then also looking at the genomics of the actual tissue. And so the interesting thing about GTN is that most of the time we don't actually have pathology to look at, that we're really basing this diagnosis of cancer off of a laboratory trend, which is unusual and very different from most cancers. Also unusually, this cancer loves to spread to the lungs. So in my line of work, if you have cancer in your lungs, you're a stage 4, except if you're GTN. So it goes to the lungs, and so it's kind of it makes you a stage 3. There's also a really strange thing called this WHO score. So this is, at least in GYN cancers, the only one that has something like this. And so it basically takes some individual criteria of the patient that's sitting in front of me, and it basically gives me a risk score. How aggressive do I think this cancer is going to be? And it basically tells me if I can use one single agent of chemo, or if I need to use kind of a combination strategy, which is a lot more aggressive and more challenging for patients to tolerate. There's been some research done about GTN. The hard thing is that it's not a terribly common cancer, and so doing research is hard. But this sort of question gets to the point, patients love Facebook groups. There's lots of social media groups about all the different cancers, and your patients love to come and say, I met this person who lives across the country. They told me to ask you that. That is part of being a doctor. You get used to it. But there was one study recently that looked at whether or not doing another uterine evacuation or a DNC could be helpful. And in this situation, it actually was. It saved about 40% of women from getting chemo, which is a big deal when you think about these are young, teenage, 20-something, 30-something-year-old women. If we can keep 40% of them from having to get chemo, that's a big win for us. There's lots of different chemotherapies that we won't go through. In general, though, you'll look here in the right-hand column. With these chemotherapies, the response rates or the cure rates are pretty high, which is, again, unusual for my line of work. But these patients are often very, very curable, which is good. And that's probably one of the first things I tell them when I meet them is, yes, you have cancer. Yes, you need chemo. And we are probably going to cure this cancer. Let's see. I'm going to skip over some of these slides. So this is sort of a different patient. She was 31. She had a term vaginal delivery. So she had a beautiful baby boy at home, and she started having really bad vaginal bleeding, worse than right after her delivery. And so she went to the hospital. They thought maybe she had part of her placenta stuck inside her uterus. So they went back in, they scraped her uterus, and the pathology came back something called a choriocarcinoma, which is in the spectrum of these GTNs. And they checked a pregnancy level, which at 9 weeks after a delivery should be negative. Hers was pretty darn high. The CT scan isn't perfect, but what we're seeing is kind of the junction right between the lungs and the liver. So on the top hand picture, we're starting to see the liver and the spleen come in, but the bottom black part, those are the lungs. And if you can sort of tell up here on the top picture on the left-hand corner, there's a metastasis in the lungs. And on the bottom picture all the way to the right, there's another sort of circle at the top. That's another lung met. So this is a new diagnosis of a metastatic cancer with a 9-week-old baby at home that she's trying to breastfeed, and she herself is trying to recover. We did all her scoring. You know, these little red boxes spoke to her score. She ended up being high risk. And so she got multi-agent chemotherapy, which is really hard. You get chemo every week. There's no week off. It's exhausting. And then you think about, gosh, she's got a 9-week-old baby who's not sleeping at home. I have to tell her she can't breastfeed anymore. This patient was understandably in tears. It was an overwhelming appointment for sure. She got a lot of chemo. We won't go through all the toxicities and things like that. She got a lot of chemo, but she was cured. And she's considering whether she wants to have a second baby now. I think her first is about 2.5. She's still traumatized from chemo the first time, but she's thinking about it.
Do we know if there's any increased risk of having another one of these cancers for a second?
That's a great question. So we know for those molar pregnancies, if you've had one molar pregnancy, you're at risk for developing another one. There's even a very rare hereditary form of molar pregnancies where all you can do is have molar pregnancies. These women can never have a term delivery, which again is devastating. I've probably seen 2 patients in my lifetime with this. And so they end up needing, reproductive endocrinology for egg donation, because with their own eggs, they will never have a regular pregnancy, which is hard.
Another random question.
Mm-hmm.
What do we know about the genetics of the child in these cases? Is there any increased risk of cancer for the kids?
Not that we know of. People have looked at least at fertility following chemo for these women. And, some chemotherapy can be toxic to ovaries and to oocytes that haven't been ovulated yet. And so these are one of the cool things about GYN oncology is that it's not a silo. We work with tons of different groups. So for these patients, I work really closely with the reproductive endocrinologists, and we're having our patients see them to talk about anything we can do to protect the ovaries before we start on chemotherapy.
No.
If maybe there's a patient who needs to have her ovaries removed, do we do some egg harvesting and embryo creation so that down the road she can have IVF to get pregnant? So it's a nice sort of collaboration to try and affect a woman's goals of being able to, have her own child, and however that may look like. Maybe it's a surrogate, maybe it's IVF,
Yeah.
So
another specialty, speaking of collaboration, another specialty I've talked to before is reproductive psychiatry or perinatal psychiatry. Do you work with them at all?
So not necessarily directly. However, at the reproductive endocrinology office, they have a reproductive psychologist, and pretty much every new patient will meet with them before they undergo some sort of reproductive technology.
Nice.
Because if people watching, if you've ever tried to get pregnant or know people that have tried to get pregnant, it is fraught with a lot of stress and anxiety and depression and,
cost, financial issues. Yeah.
Financial issues. And it's just hard. And I think that is a really important role to have in those clinics for sure.
Awesome.
Yeah.
Okay.
This lady here was another patient of mine who I saw. She was 33 when I first met her. She came to me and she said, my last pregnancy was 3 years ago, but I've been breastfeeding and I've never really had a period, because many times when you're breastfeeding, you're not ovulating, you're amenorrheic. She stopped breastfeeding, and then all of a sudden she went to the emergency department throwing up blood, coughing up blood. And she had a positive pregnancy test. And she said, there's no way I could be pregnant. And her pregnancy hormone level was 800,000, above 800,000. This CT scan off to the right, especially the bottom one, is more obvious. She has innumerable metastases to her lungs. On both sides. This scan doesn't look, she had tumor eroding into her trachea. And so that's why she was coughing up blood. Admitted to the ICU. Lo and behold, she had choriocarcinoma. So she started on a 10-month course of chemo. Every week she got chemo for 10 months. She had 2 kids at home. She had a 3-year-old and a 5.5-year-old at the time, and it was exhausting. She's now been off chemo for 10, almost 11 months. Fingers crossed she's in remission. So we'll celebrate when that year mark gets to it. This speaks a little bit, this slide, just about risk of subsequent molar pregnancies. The more moles you have increases your likelihood of having another mole. But most of these patients do really well. So the cure rates are pretty darn high, but they're not 100%. We do have patients that recur. I'm not going to go into these surgery slides because we don't operate very commonly. I was going to hope to see if there were any more. Another thing to think about in terms of reproductive endocrinology is there are some reasons why an HCG or pregnancy test can be high even though you're not pregnant. So GTN is one of them. We'll talk about, well, that's not the fun one to talk about. Let's see. So have any of you guys ever heard of heterophile antibodies? Probably not. No. So especially people who have been raised around animals, particularly rabbits and horses, develop these antibodies. And when they do a serum blood test for HCG, the test uses most often HCG antibodies from horses or rabbits. And so if you have spent a great deal of time, you may have developed these antibodies, which can make you look like you're pregnant when you're not pregnant, which is a crazy thing. So that's always the thing in the back of my mind is have we thought about have we thought about that? So I don't know. Little fun fact.
Very interesting.
Horses and rabbits. I don't know. I wasn't going to go through. I'm trying to see if there's any more fun, exciting sides. A lot of these are chemo things, which y'all probably are not excited about. But
interesting question about PCOS and any sort of other hormonal dysfunction. Is there any increased risk, maybe outside of the obesity that typically is around that as well? Any other increased risks of gynecologic cancer from that?
Oh, that's a good question. I think, to me, the first thing I think about is PCOS, the risk of obesity, and the risk of uterine cancer. A lot of the young patients I see with uterine cancer, and I have several in their 20s, unfortunately, have been diagnosed with PCOS, irregular periods. And then finally they get so irregular, we do a biopsy of the lining of their uterus, and that's how we diagnose their cancer. But PCOS has not really been linked to other things like ovarian cancer or things like that. It's mostly related to the weight, kind of adipose estrogen.
Yeah, interesting. What about another question here from Madison? Any correlation with birth control and gynecologic cancers?
Yeah, there is. So birth control pills are actually really helpful. So we think, so fun fact, ovarian cancer, we think the ovaries are probably innocent bystanders, that we think most ovarian cancers actually start in fallopian tubes. The ovaries take all the blame.
I'm just hanging out here doing my thing.
Hanging there, and
I'm not the bad guy.
Blames me. But there is excellent data out there that birth control pills reduce the risk of ovarian cancer or fallopian tube cancer, however you want to call it. The fewer times a woman ovulates in her life, the lower the chance of developing ovarian cancer. So whether that's because you've been on birth control pills, whether that's because you've been pregnant many times, if you've been breastfeeding, those are all protective factors for ovarian cancer. Birth control pills have also been shown to be protective against colorectal cancers and things like that we don't exactly understand. But birth control pills are actually very good. They also can help protect uterine cancer too, especially if you are taking excess progesterone. It can help balance out some of that excess estrogen that's being produced. So things like IUDs, Mirena, or I should say progesterone releasing IUDs are very protective for uterine cancers and things like that. So IUDs are my best friend.
Yeah. Awesome. All right. I'm going to bring on some students to ask some questions. Let's see if anyone wants to play along.
Okay.
We'll see. Surgical skills in the operating room as they come on. Learned over time, or something you need to have a baseline competency coming in?
They're skills. So just like anything else, some people are born with these inherent wonderful surgical skills and others have to work really hard to get there. I've trained plenty of residents and fellows now at this point, and I've seen a wide spectrum. So I don't think surgical subspecialties have to be only for those that are naturally gifted. That with repetition and exposure and practice, you can absolutely get there. Yeah.
That's what I like to hear. Get there.
You get there. And just a plug for Gyn-Onc, we're the only oncologists that do both chemo and surgery. So for any other solid tumor, you have a medical oncologist who does your systemic therapy, your targeted agents, your chemo, and then you have a surgical oncologist who does your surgery. But in Gyn-Onc, we do both, which I love. Keeps us busy. But
why is that?
I don't really understand. There was, as Gyn-Onc evolved as a specialty, there was probably a reason, but I don't know. I'd have to ask some of my mentors have a better idea.
Interesting. All right. I don't know why nobody's coming on. If this new interface is messing with people coming on as well. So I just
that's okay.
A bunch more. Let's see, there's some other good questions.
Oh.
All right, here we go. Now we're cooking. Alex, hello.
Hello.
Hey, Alex.
What's your question?
Oh, I didn't have a question. My computer keeps popping up and out. I don't really know what's going on, but no question here.
Okay, goodbye. Why'd you raise your hand then? Sawith, hello. Unmute yourself, Sawith. I muted you.
Can you hear me?
Yep.
Hi. So my question for you is uterine cancer generational? Right? Do you see like a common trend? like let's say from the maternal side?
So that's a great question. Most of the uterine cancers are sporadic, meaning that they are not passed down from generation. The risk is not passed down from generation to generation, right? But there are some uterine cancers that can be associated with hereditary syndromes. So Lynch syndrome in particular, classically we think about colon cancer with that, but usually in women, the presenting cancer is often a uterine cancer. And so that, and then also some other genetic syndromes, BRCA1, even though we think breast and ovarian cancer, there's actually some evolving data that it may also be associated with some high or aggressive types of uterine cancer. And so I would say the majority are just sporadic, bad luck. But there are some families that are at risk for hereditary uterine cancers.
Oh, wow.
Yeah, that's a great question.
Also, one last question. First of all, like you've combined two fields I'm really interested in. So I just want to know what your work week looks like.
My work week? Yeah. So I'm an academic GYN oncologist, private practice GYN oncologist. Their work week is going to look different. But for me right now, I operate 1 day a week. I have clinic 2 days a week. And then I have research or academic time the other 2 days a week, because in my spare time, I'm also the associate program director for our residency. And so I'm pretty involved in their education and evaluation and things like that. So it's never a dull moment. Every day is something different, which for me is really helpful. I'd get bored if I did the same thing every day.
That sounds really nice.
Nice.
Thanks,
Ellen.
You're
welcome. Nice to meet you.
Spare time, huh? Spare time. That's a thing.
Yeah, it depends on the day.
Emily, unmute yourself.
Okay, is that the unmute? Okay.
Yeah.
Yep.
My question was like for the GTNs. What is the prognosis for like how cancers tend to have like 5-year survival rates depending on like what it is? What is it for this?
It's pretty darn high. It's probably over, there's probably over 85 to 90% are alive at 5 years. It may even be higher than that. For GTN, we don't necessarily think about 5-year survivals. It's more the individual cure rates of the chemos, but super, super high. Knock on wood. Over the last, I'm going to jinx myself now by saying this. Over the last decade, I haven't had a patient with GTN die.
Awesome.
I keep forgetting that my mom technically is a cancer survivor because it was uterine cancer and it was like dealt with like via just one operation and that was it.
Yeah, my mom, the same thing, had uterine cancer and was cured with surgery. Yep. Some of them are, which is really wonderful.
Awesome.
I hope mom's doing okay.
Yeah, she is.
Good.
Anything else, Emily?
No, that's it.
All right, thanks. Brock.
Hey, can you hear me okay?
Yeah, hey, Brock.
More than okay with that sexy podcasting microphone you got there.
It's
Yeah. Thanks. So sorry if this was answered, but I had a question about research. And so the majority of oncologists that I've talked to have talked about a large part of their practice being research, like almost 50%. I was wondering if that was true for you. And also to ask another question here now, how important do you think it is to get into cancer-specific research in medical school and even during residency in order to secure the fellowship for?
Yeah, those are great questions. So for me, research is probably my life is like a triangle. So I've got my patient care, education, and residents and fellows, and then research is the third part of that triangle. So I'm sort of a third, but different people may have different proportions. I do research. Most of mine is considered clinical. I don't do basic science research or things like that. I do research in how to improve lives of cancer patients as they're going through it. So I do a lot of research about palliative care and the end of life, how to improve the symptom burden for women with cancer, how to communicate more effectively about goals of care for cancer treatments. So that's really where my research focus is. But there's so many different, each of my partners does something different. I would say, especially as a pre-med, med school, even beginning into residency, being so niche and having GYN oncology or oncology research in general is not necessary. I do think it's important to sort of dip your toe into research and learn about it. I think more med schools are looking for research experience, but it doesn't really matter what at that stage of the game, just that you have been exposed to it and are participating in it. And then, you know, getting into residency, figuring out you want to do gyn-onc, that's where you start to get more kind of laser focused about the particular field. But in residency, I was doing research on contraceptive options for adolescents. You know, I didn't know that I wanted to do gyn-onc right away. And so I was doing research on other things, and that's okay.
Right on. Thank you for the detailed answer.
Yeah, you're welcome.
Thanks, Brock. Hello, Kaylee.
Hi, I was wondering what your pathway was like to become a gynecologist.
Sure. Yep.
Thank you.
So after I finished med school, I did a 4-year residency in OBGYN and then a 3-year GYN oncology fellowship. So 7 years total after med school.
Thank you. That's my only question.
Okay.
7 short years.
7 short years.
That's all. Yeah. Any tips for anyone watching this on how to pick the best program for them?
You know, that's a great question. How to pick the best program. You know, programs are programs because they're accredited and you'll get the appropriate number of cases. You'll get the exposure that you need to because they're an accredited program. Mm-hmm. To me, it comes down to the people. Residencies and fellowships are hard. You're at work a lot. It can be exhausting. The most important thing to me was that when I was at work and working hard, I wanted to be around a group of like-minded people that I felt were going to be supportive, that I got along well with, that I felt like it was going to be home. And so to me, it was sort of that gut instinct was like, do I see myself there? Do I see myself with these people? Are the kinds of people that I want to train under? And so that's sort of where my mind was. Other people may feel differently though.
Yeah. I want to rewind just a second for one of the earlier questions I asked. You talked about your approach with patients when they come in and basically talking about empathy, trying to understand who they are and all of the things that they're coming with.
Yeah.
That is 1000% reflected in all of your doctor scores, your ratings online. I don't know if I've ever seen a physician with like almost all 5s across the board.
I'm a touchy-feely physician.
Physicians get murdered on review sites, and you, I guarantee, because of your approach of just being empathetic and trying to understand, are crushing it. So,
well, thanks. I'm trying.
Proof is in the pudding there. Stephen, hello.
Hi, can you hear me okay?
Yeah.
Great. So thank you for your presentation. I really loved it. So my question involves how you approach a conversation psychologically with patients who have stage 4 cancer.
Oh, gosh.
I have a family friend, and her mom has cancer at the moment, and she was in remission for about 6 months, but it recently came back. So she's going to have to start combination chemo again soon. So I just want to know how you approach it.
I'm so sorry to hear that. It's hard. So a caveat to this is that I teach communication skills. They're that important to me that I went to a bunch of courses to learn how to do it better and subsequently now teach them myself. So that's my caveat to this. Listen, oftentimes when we're having conversations with people, while they're talking, we're already in our head thinking about what we're going to say next and not really listening to what the words are coming out of their mouth. Listen and respond. I do a lot of responding to emotion. Patients will share with me things, sadnesses, hopes, fears, things like that. And, you know, I say, gosh, you know, I can't even imagine what that feels like. I can't imagine how crushing this news is. You know, I wish we were having a different conversation, sort of just reflecting back. Oftentimes, you know, there's different things, reflecting back emotions. You know, some people just want to know that they're supported. So, you know, whatever happens, I'm going to be here with you. I'll be a listening ear. You know, I don't know what to say. Sometimes that's the best thing. I don't know what to say. This is really hard. And that's perfectly fine. Sometimes that's all people want to know is that, you know, you're there. So I would say listening is probably the best thing. That you can't solve the problem. So don't try. But you can be there and you can be supportive and you can listen. And sometimes that's like the best gift you can give someone.
Thanks so much.
And notice that you never once said that the doctor should say, I understand.
No, that is the worst thing.
Okay. No
you
taking.
never want to, unless you have been in that particular situation, we can't understand.
Yeah.
I can't understand what your friend's parents or mom is going through. And they'll say, I can't even imagine what that's like. That must be crushing. That must be devastating. But if you, the time I say, gosh, I know that's really hard. I understand. The patient will be like, you don't know anything. Have you ever been through this? It's like a common mistake to really ruin the patient-physician relationship. So don't understand is like, no.
Don't do it.
Don't do it.
I teach first and second year communication here at the University of Colorado School of Medicine. So it's
nice.
So important. So important.
So important.
Yeah. It's much easier for me in the setting like that. And then I got to work on my communication with like my kids and my wife. And,
I know.
Personal stuff. It's very different.
I use the same skills though. My husband will be like, are you vital talking me? Yeah, I am. He's like,
Have you researched any of the Alan Alda communication stuff? Have you heard about it?
Mm-mm.
So Alan Alda, the actor, he is really big into communication specifically for healthcare workers. So it's
I'm gonna
very
have to
interesting.
look into this.
Yeah, check it out.
Cool. Yeah, thanks.
Monica, hello. Unmute yourself.
Can you hear me now?
Yep.
Mm-hmm. Hi, how are you?
Hey, how are you?
All right. So I had a question. You mentioned for the GTN diagnosis that it's diagnosed with a laboratory trend versus pathology. What does that mean exactly?
Yeah, so oftentimes for most cancers, we have a piece of tissue that the pathologists are looking at under the microscope to actually give us a diagnosis. That is the most common thing. Even in other medical problems, lupus or things like that, a lot of times there's biopsies. But for gestational trophoblastic neoplasia, we're not often getting biopsies for a few reasons. These cancers can be really, really bloody. And so even a tiny little biopsy can cause massive hemorrhage. So we don't want to put the patient at risk. And then also someone way smarter than me with a lot more street cred has developed these sort of rules to diagnose it based on their blood tests. So we're using the trend of their blood tests over time to reach that criteria for cancer.
Okay.
It's very specific to this particular cancer too.
Okay. And you said that it spreads to the lungs. Do we know why it spreads to the lungs?
Different cancers like to spread differently. Some cancers love to spread through the bloodstream and so can go to the lungs or the brains or things like that. Other cancers like to spread through the lymph nodes. Other cancers just kind of grow serially, like they just start off as a tiny little marble and they just grow radially from there. So each different kind of cancer has developed its own pattern of growth, and that's just the way GTN has developed. Mm-hmm.
So, would you say that there could be a similarity between lung tissue and uterine tissue? Is that
No, it just happens to be that a cell breaks off and hops aboard in the bloodstream and lands up in the lungs. So
there's not really. Okay.
Yeah. No, that's a good question though.
Like Hawaii for tourists. Yeah. This is a nice place. I'll hang out here.
There's lots of oxygen here. I might as well make myself at home.
Do you use robotics during surgery? Is it just normal?
I do. Yeah. So there's lots of different ways we can do surgery. So sometimes you need a big incision in your belly called a laparotomy. Sometimes we'll do things with just what we call straight stick laparoscopy. So just with 4 little incisions on your belly. And then other times we'll use the robot. There's pluses and minuses to each different route of surgery. It just sort of depends upon the patient that's there, what I need to do, what medical problems they may have and that's part of the decision making for surgery. Mm-hmm.
And is that a lot harder to use than normal?
It's just different. It's just different. Mm-hmm. It's cool because it's 3D. So when you're operating robotically, everything is, you have a third dimension, which is really neat, which in regular laparoscopy, everything is 2D. So you have to develop that sense of depth perception, which takes, it's part of surgical training. You figure it out. The robot is nice because you don't have to do that.
One last question.
Mm-hmm.
How do you fit kids into your schedule? How does that work?
Oh gosh. It's hard, but you make it happen. I am very thankful for daycare. I'm also very thankful. My husband is also a physician, but his schedule is complementary to mine. And we have some really good friends that love us very much and will help out in a pinch. It takes a village.
It does. Thanks, Monica.
Thank you.
Madison, hello.
Hi, sorry, excuse my bun.
And
if my dog barks, please
that's
excuse
okay.
that. It's her supper time. But I was interested in your research.
Yeah.
I want to be a psychiatrist, but I also work in, I'm a CNA right now. And I work a lot with palliative and hospice care and stuff like that. And it's one of probably the hardest parts about that kind of job. So like, how did you get involved in that sort of research, if that makes sense? Because like I said, I want to do psychiatry research. And that.
Yeah. So it started because I actually liked having end of life discussions with my patients, which sounds very morbid, but I realized in scenarios where I can't cure their cancers, if I can help them feel better and die with dignity and not be in pain and be surrounded by their loved ones, that's a win. And so being able to have those conversations to really tease out that information was really rewarding to me. And the patients were thankful for it and the caregivers were thankful for it. And so then I said, I want to get better at these skills. I see the value in them. It's important to me. And so that's sort of set off that trajectory. And then kind of once I clinically saw how important that was, I sort of decided, all right, I'm going to study this more to figure out how we can do it better.
Okay. Yeah. Thank you. It seems so interesting.
Well, good luck.
Thank you.
If anyone else is interested in end of life care, we had Dr. BJ Miller on eshadowing very early on, and he's very well known hospice and palliative care physician who will hopefully get more people interested in it with all of his writings and musings. And do you know BJ?
I don't.
Oh, amazing human being that you need to know.
Oh, awesome. Okay.
Yeah. So BJ is a triple amputee. He was electrocuted in college by being on top of a train car that had an overhead electrified wire that arced through his watch. So near-death experience. Decided to go in medicine after that, and has spent his life doing hospice and palliative care. And he had the Zen Hospice Center, I think it's called, in San Francisco for a while. He was the medical director there. And now he's moved on to a new model of hospice and palliative care, almost online concierge, trying to help as many people as possible, because it's something that, unfortunately, again, going to what I was talking about earlier, I wish all physicians came with the empathy that you approach your patients with. I also wish all patients or all physicians understood the importance of palliative care and hospice, and understanding that it's not giving up on patients and making it clear to patients. And it's so important to get those services involved as soon as possible.
I agree. I could not agree more.
Yeah. Yeah. Anyway, close to home right now, unfortunately for
I know. I'm so sorry.
Dr. Brittany Davidson, thank you so much for coming and hanging out with us.
Oh, my pleasure. It was wonderful.
You're amazing, and thank you for sharing your wisdom. And hopefully, we'll get some more empathetic physicians in the future.
I would love it.
From your talk. So I appreciate you. Thank you so much.
Bye, everyone. Have a great evening.
Thank your significant other for watching the kid.
I will. It's been pretty quiet, which is I'm happy about. So.
Wonderful. Everyone have a wonderful night. Bye.
Bye, everyone. See ya.